First, good afternoon, everyone, and welcome to the first of 3 webinars devised by the EFIC COVID-19 Task Force. This session has 2 chairs. Myself, my name's Felicia Cox, and I'm one of the 2 nurse members of the EFIC Task Force, which is led by Dr. Roger Naggs. Long COVID is also known as chronic COVID syndrome and long haul COVID. Long COVID can affect nearly every organ system with sequelae, including the respiratory and cardiovascular systems, the nervous system, resulting in cognitive dysfunction, post-traumatic stress disorder, gastrointestinal disorders, dyspnea, fatigue, muscle weakness, insomnia, and low fevers. We have 2 speakers today, but I'm also joined because I have a co-chair, Dr. Patrick Hill. The first of our speakers is Dr. Ian Frayling. Ian is a clinician by background, but he lives with long COVID and will share his experience of the challenges he faces. And Ian will introduce himself. Our second speaker is Dr. Andreas Koch. Andreas will provide us with an insight into how patients in Germany access healthcare related to long COVID. At the end of the presentations, there'll be a question and answer session. We would encourage you to submit these questions, your questions, in the Q&A section. So please join me in welcoming Dr. Ian Frayling.
Thank you, Flick. So I'll just, okay. I cannot start my screen share while the other participant is sharing. Okay, I'm trying to share my screen, but it says someone else is sharing theirs.
Flick, I think Felicia, you have to stop sharing your screen.
Yes, yeah. Felicia, can you click on stop sharing your screen? It should work okay. Now, Ian.
Yeah, very good. Okay. Oh yeah, that one. Right. So can everyone see that?
Yeah, that's good.
Okay. I'll just hide you all because I know who you are. Okay, so yeah, as Flick said, I'm a clinician by background. I'm sort of semi-retired because I took early release from the National Health Service here in the UK a couple of years ago, but I haven't retired from medicine. I have a number of honorary appointments. And that picture you could see of me in the purple robes was my receiving the honorary fellowship of the Faculty of Pathology of the Royal College of Physicians of Ireland, with which I have a nice connection. So I just need to stress this is a personal statement. I'm not speaking as one of those appointments. I'm a Northern European. I'm a geneticist, so actually Caucasian is a useless term. It doesn't describe anyone. Northern European is what I am. I'm now 62. I'm 1.8 meters and 100 kilos. So that puts me at the top end of bit fat. I've got blood pressure, high blood pressure, so I take Ramipril. I'm on a torvastatin to keep my lipids down. I've taken aspirin for a long time, like most of us in the business of hereditary cancer, because we know that it has such a good anti-cancer and cardiovascular health benefits. And I'd taken vitamin D3 supplements since the autumn before COVID, because a good mate in the blood donation business had put all her regular donors on it in Denmark because their levels dropped every winter. So I thought, oh, I'll start that. Might be relevant, might not. So I qualified in 1982, so I've got 40 years in as a doctor. I'm a specialist in genetic pathology, so I do things like interpret genetic variants. I'm a cancer geneticist, so I specialize in hereditary cancer. and I operate at the international expert level. In fact, the World Health Organization invited me to write sections for their blue books. I'm an assessor for UK NEQAS immunohistochemistry, which is fairly mind involving. I'm president of the Association of Clinical Pathologists here in the UK. My wife is a professor of cellular immunology and immunotherapy. We have a daughter who's in corporate financial public relations, and I've got a large number of other things I'm interested in, as well as medicine. And last summer, after I developed long COVID, somebody tweeted, "What single word will you use to sum up long COVID?" And I replied, pain. And I forget how many likes I got, but it was quite a lot. So I'm not a specialist in pain, except as I feel it. And I'd say that pain for me is what hurts, upsets, distresses, causes a response, mental or physical. It can affect your psyche or your physical body. How do you compare all the different sorts of pain you can have? It's subjective and objective, and is a little pain for a long time as bad as a small one for a short time? A lot of pain for a short time? I don't know. I can't compare it, but I do know that on a personal scale, these are the ones that have hurt me most in life. I put 11 out of 10 there for biliary colic because when the paramedics found me screaming and thumping the floor, they asked me to do some arithmetic, which I sort of replied in as pleasant language as I could reply, that I'd done 10 out of 10 before and assumed I'd faint if it got worse, so shall we call it 11? So how one scales things can vary with time. SARS-CoV-2 infection. I drew this slide last year, but it still holds. You can be asymptomatic or you can develop COVID-19. And you can get various gradations of severity of COVID-19, and you can end up in hospital or in the community or somewhere in between perhaps. And 3% die, mostly those who go into hospital round here in the UK, but you can survive. Although I put survive in quotes because you can survive to have long COVID, which some describe as a living death and it takes my life away, which is fairly painful really. For me, it started 28th of February when I visited my local city to get my hearing aids sorted out on the train. And in retrospect, I reckon that's the day when I caught it. Then I cut my knee in the garden on the 1st of March and it was a dirty wound. I had to go to accident and emergency, 12 stitches and a tetanus jab. So I took some pictures at the time and I hope the nurse who did such a fantastic job stitching my knee did not catch COVID from me. Because on the 3rd of March, I developed some symptoms and it wasn't at all clear that I had COVID at the time because this was so early on. I had a headache, felt out of sorts, bit of a fever, but then I'd had a tetanus jab and I had this damn great wound that was actually really, really painful and reddened. And I thought, oh, it's infected. I'll have to have it drained in theatre or something and antibiotics and all that. Anyway, over the next few days, I felt increasingly tired, fatigued, loss of appetite. Coffee tasted disgusting, muscle aches. I had a strange 1st-degree burn all over my back, but it wasn't red and there was no rash. I had tingling down my arms, which is a bit weird. I started coughing every now and again at night, non-productive. Absolutely no symptoms of upper respiratory tract infection. And it was a real question of, well, have I got COVID or not? And then it decided to make its mind up and I took to my bed on Friday the 13th, which was day 10. And I realized I would have to cough and drink for my life because it was really bad. I had a bone-cracking fever, an appalling headache by this stage, severe muscle and joint pain. I think that was almost the worst. You could not get comfortable and it kept turning me over, which maybe was beneficial. Now we know that proning helps. I was getting coughing fits when I would pass out, difficulty sleeping, but terribly tired. Should I take non-steroidals? Should I keep up with my ACE2 inhibitor? Didn't know. I asked my wife to put some diclofenac gel on my really painful sacroiliac joints, and I screamed. I learned to warm it up before it was applied. I had delirium, racing thoughts, confused. As a diver, I thought, oh, my wife only has to go to the dive shop, get me a tank of 36%, and I'll be all right. Of course, we now know that's probably not so bad. I was collapsing, going to and in the bathroom, hadn't eaten for days, terribly weak, finally stopped my ACE2 inhibitor when my blood pressure was crushingly low. I was really frightened. I lost track of time. I lost a day. I thought it was Sunday when it was Monday. I noticed that my breathing was going up and down, hypoventilation in a Cheney-Stokes type pattern. But I could still move gas in and out of my chest. So I reckoned, oh, that's all right then. No need to pull the ripcord and go to hospital. But I was in fear of my life and I was frightened to sleep. On day 14, I rang my GP and I was her first patient. And I think I was more helpful to her than she was to me, but it was helpful ringing a medic and speaking person to person. I started to get an ever so slightly little bit better. I ate a bit, which really set my guts off, which was painful. And I just attributed it to re-eating, but now we know that SARS-CoV-2 goes for your guts. I took some multivitamins because I hadn't eaten anything for 10 days and I'd lost 7 kilos. I was unable to shower, but I thought I don't smell, but it must have been really painful for those around me because I probably stank to high heaven. I got stuck in a bath after I'd run it. I had to roll out over the side. But afterwards I knew I was in for a long haul to recover. Well, I started to recover, but after about a month, I kind of relapsed with feeling awful, malaise, weakness, muscle aches again, attacks of shortness of breath for no good reason. I hadn't done anything. I was just suddenly short of breath, thumping tachycardia, very slow thinking that people then started to call brain fog. And I thought, oh, well, that's what I've got. But it was difficult to work it out because I had it. Trouble finding words, and I still do to some extent. Sleep disturbance. It was like being jet lagged from 3 different places at the same time. During these chronic relapsing attacks, I'd get irritable bowel and from top to bottom. Sudden attacks of anger, irritability, shakes and weakness relieved by sugar. Waking with nausea, with or without dizziness. So I've had all possible combinations of that. Funny little sensations everywhere, muscles twitching, transient foot drop. And it was the unpredictability, the relapsing remittent. You could be in a bad phase, a good phase. You could swap from one to the other within a couple of hours, or it could take 2 months to get better. And I think the fact that there was at that time no prognosis, no specific treatment was very frustrating, debilitating. I was unable to function at all. I could hardly read anything for any length of time. I could watch TV. It was frightening and depressing. In a different sort of way to COVID, it was more sort of drawn out. Here's some of my antibody tests because I just managed not to get a virus test here in the UK. So my long COVID, it was sort of cardiac and respiratory and irritable bowel to start with mostly. Then it was replaced by more neuro as it got towards last Christmas. Inability to read much, yeah, I've mentioned that. What was good for the soul was that I knew I had immunity. My wife's department sent my B and T cells to Oxford to help with vaccine development. I gave plasma as a national initiative to help those who did not have antibodies. I contributed to both NICE and WHO guidance and our research and development by giving samples to people. Oh, here's my T cells because of my wife's department. And these little boxes here are the 24 T cells to anti-SARS receptor binding domain that went to Oxford for sequencing to do reverse molecular modeling. What was good was going shopping because I was immune during the lockdown and I could just about manage that and get home and sort of crash out for the rest of the day. Found others on social media with it, formed a group. Media exposure. I got my name on a paper in the BMJ about a new disease. I realized it has a mind of its own. Once I accepted that and that it was chronic relapsing and remitting, I could kind of cope with that. I tried magnesium supplements. They didn't help, but it did a lot for my morale. And learning that pacing and negative tests are good to know. But really what was bad was relapsing and remitting, misunderstanding and mishandling, so many others with it, unable to help them. There were loads of studies on acute COVID-19, but people just didn't give a damn about long COVID, especially treatment. And yet we could have cracked all those questions about does this or that work very quickly. It was really painful having idiots in charge. The demand for evidence-based medicine, or you get nothing. Well, why not use common sense and a medical degree? People telling us what I and we have, especially biopsychosocial idiots who tell you it's all in your mind. Very bad, losing my temper with my family and distressing and burdening my family. I was worried about disturbed sleep until I stopped worrying about it. Then it wasn't a problem. I just slept and woke whenever I wanted and stopped worrying about it. Worrying about whether I could still do what I wanted, and did I have serious organ damage like myocarditis that was being reported. There was a curious one of stuff that was good but distressing. Scenes of affected people living and dead, and it still upsets me very deeply. And scenes of distressed healthcare workers and their funerals when I went to my local hospital. There's a clip here that came out today on the BBC. You can watch it. It's a local anaesthetist that I know who has had to go back to Sweden because her heart does not function and there are no long COVID clinics in my country. Pathology of the disease is good but distressing. Here's some pictures tweeted by a colleague locally of post-mortem kidneys with microthrombi that had been responsible for killing the patient. Really good review here. I'm doing it a paragraph at a time. I can't manage more than that. So finally this year, I got to take part in a cover scan study in Oxford where they do MRI studies of multiple organs. And they found that I had a normal heart, which is good to know, but my liver, pancreas and right lung have taken a hit, which is interesting. More pain and distress because of government level denial, failure to implement UK national guidance, the statement by the government that there will not be any clinics, sorry. Well, who's sorry? Not us with the disease. Then I was asked to give evidence to the government, which felt good in a sense. And then I was contacted by a local consultant running a clinic as an extension of her respiratory clinic, so she wasn't contravening their little rule. She takes my history. I say, well, I'm not so bad. I'm perhaps on the getting better phase. And then she orders a CT of my brain, which showed maxillary sinusitis, for which she put me on a nasal spray. And that made me feel better because I had a chronic deep-seated infection. But it also showed either arachnoid granulations in my cerebral veins or possible thrombosis. So she asked for a repeat with a venogram where they show up your veins, and it showed that I have clots in my head, in my sagittal, transverse and left internal jugular. And when a colleague tells you she can't explain how come I'm still here, I think it's perhaps aspirin, it's shocking. You go into rabbit in headlights mode. There's maximal multidimensional distress. It's a kind of slightly delayed action, an extended grief-like reaction because of what could have been, what might be on anticoagulants. How many other people are out there undiagnosed and untreated, especially as I had no headache, the classic herald's, red flag sign to get you a CT brain. The dangerous, unsafe policy in my country and the distress to my family. All these are very upsetting. So just to finish off, if I revert to being a patient now rather than a doctor, and like the paramedic when I was screaming on the floor with passing a gallstone, when somebody says, where does it hurt? This would be my reply. And I'll leave it there. You're muted, Flick.
Thank you very much indeed, Ian. I'm in the middle of a thunderstorm with lightning, so I had to mute myself.
Oh,
what you have very clearly demonstrated is the complexity of this disease and the significant impact it has, not only upon your ability to function on a day-to-day basis, but the impact it has on your ability to work, challenges with your family, those relationships, very similar to other long-term conditions, but this is very unique. It is a plethora of symptoms which are very unique. So I would just like to say thank you very much, and be prepared for the Q&A section.
Oh yeah, that's all right. I'm used to that. That's my day job.
Thank you very much. So I'm just going to hand over to our second speaker, who's Dr. Andreas Kopf. And Andreas, please take the floor. Thank you.
Well, welcome everybody. There will be no slides. We tried old-fashioned, and the reason is that my part will be not to show you studies on certain symptoms. You already heard from Ian that there's a plethora of symptoms, and that there's high symptom load, and that there are a lot of questions, but not a lot of answers. So what I can tell you is how we tried to come closer to this problem, because in the beginning, we didn't know that there was a problem. I'm working in pain and palliative care. We had a palliative care service, especially for COVID wards and for the ICU with the COVID patients there. And we were kind of surprised that first one, then a second and a third patients came up into our outpatient clinic complaining about symptoms. And very early, we found out that it was not the patient we expected, the one who had been on our ICU, but these were patients who had, I would say, mild to moderate acute infection, but they have continuous infection going on. And this is why we thought that there has to be an answer. So we kind of linked together here within the Charité Medical University with people from neurology, from physical medicine, cardiology, pulmonology, and try to kind of make folky how to take care of these patients, how to assess them, and how to allocate them in a way that makes sense. You've already heard the kind of symptoms Ian was told you. Our own impression is that muscle weakness, dyspnea, 1 out of 4 patients more or less has fatigue, is something more than half the patients have. There's a lot of pain, back pain. There are myalgias, polyarthralgias. And then there is a number of patients with cognitive impairments and with depression and anxiety. So it is a symptom complex, which a little bit is reminding to what we already know and where we have some competence in our hospital here, what we call the post-intensive care syndrome, PICS, and what we call the cancer survivor syndrome, CSS. And since we have already multimodal programs for patients addressing the biopsychosocial and social dimensions of symptom load, we thought that until we have something causative which might help these patients to recover, that we might offer them something. So we got together as a team, interdisciplinary and multi-professional, and I think the most important assumption was that there are maybe 2 groups of patients. That's our impression. There's one group of patients who had severe acute illness, patients who had been in intensive care, maybe even had ECMO. These are patients who have a slow recovery, but usually within the first 3 months, they kind of have a lowering of the symptoms. On the other hand, we have these patients who had been at home mostly, or were on a peripheral ward. They had mild to moderate COVID. And these patients often right after the infection have kind of relief, but then slowly symptoms kind of develop. So they are, I would call them, they are something like slow recovery patients. And we don't know yet how long this recovery lasts. We are following the NICE recommendations who say that 3 months is a good time span to say, well, this is long COVID and this is recovery part, the initial recovery part of this. Another thing which made us kind of look closer on these patients is that there have been reports from the insurance companies. Here in Germany, we have hundreds of insurance companies, but some bigger ones, and these bigger ones address this problem to us, asking what to do with their clients, since they found out that about 6%, this is the biggest insurance company we have here in Berlin, are on a prolonged sick leave. And this again stimulated our interest to work with other clinics together. The neurologists have been looking deeper into the causative treatments, especially the virus neutralizing antibodies cross-reaction with brain tissue, which might cause hyperexcitability, is one area of research under the name of Franke, Neurology Charité. You might find her publications on this, but everything is far away from that we might have something etiology specific treatment for this. So we developed a program, kind of copy and paste, well, not really copy and paste, but a little bit following our experiences we have with other complex therapies, like complex therapy, palliative medicine, in chronic pain, for example. And we built up a multimodal treatment and, very important, an assessment which is somehow sophisticated. So we have a primary assessment, every patient coming in and being presented to us as having continuous load of symptoms longer than 3 months after COVID infection, goes first through a online survey, quite a long one with 8 dimensions we look at. This is general quality of life. This is pulmonary and cardiology symptoms. This is depression, anxiety, fatigue, pain, and functional performance. And according to this first evaluation, we try to allocate patients. Some patients with very high symptom load in one of these dimensions, we might directly refer to a pulmonologist, for example, or to a psychosomatic department. On the other hand, we have patients which we invite for a secondary assessment. And this is now a face-to-face assessment. And this is done by physiotherapist. This is done by a physician who is pain and palliative care physician. And this is done by a psychologist. And after this, we decide if a patient might benefit from a multimodal program. Now, you shouldn't expect that a multimodal program after 2, 3, or 4 weeks immediately has a healing effect. And this is also not what we are aiming at. So our idea is more to look at helping the patient to get a new attitude to his illness. So we call this ACT, acceptance and commitment therapy. So kind of finding strategies for self-empowerment of the patient, to give him direction, and of course giving him also recommendations how in the future, how in the time after this, maybe specialized rehabilitation therapy after this, which is more monomodal, might be of benefit for the patient. So it is on one hand side an assessment concept we have, allocating patients to no treatment, to specialized diagnostics or specialized treatment, or to this general, I would say, multimodal treatment we have there. And it is too early to report any successes or any results from this. But of course, the whole program will be followed parallel with a scientific evaluation of the patients. So we try to find out if we are on the right track with this concept we have. The patients so far we have seen have mostly their highest symptom load on the psychosomatic with psychosomatic symptoms, but as I said, it's a small group of patients so far we've seen, so we might find out differently. And then of course, there's always a selection bias. So patients that come to us probably are the ones who are a different patient than the one who go directly to a pulmonologist, for example, or go directly to some other specific institution. What is difficult for us is how to do the psychoeducation of these patients, because on one hand side, as we heard from Ian, we don't want to question in a way the symptoms the patient has. On the other hand, we want to avoid that patients get too much involved in long COVID circling thoughts. And so we want to avoid that too early diagnoses are made. So for example, in our psychoeducation, we avoid the term fatigue syndrome, but we use a term like exhaustion, for example, or we are talking about myalgias, muscle pain, and not about fibromyalgia-like symptoms. We talk about adaptation process that is challenging, and we don't talk about post-traumatic stress disorder. What I want to say with this is that we don't want to take away the suffering the patients they have, but we want to protect them from having suddenly a load of different symptoms diagnosis, because this is what we have seen in many patients we have now evaluated, assessed in the last months, that many of them came and had suddenly so many diagnoses already. They had a fatigue syndrome, they had a fibromyalgia syndrome, they had a depression, they had a post-traumatic stress disorder, and we're not sure that it helps to go on this way. There is a nice quote I want to tell you from Michael Sharp. He's a psychologist, I think from London, but please correct me. And he wrote, multi-symptom illness does not mean necessarily multi-symptom pathology. So the best treatment initially is psychology-informed rehabilitation. And I think this might be a good approach, but as I said, it is one approach we have, and we use this as a learning system. So there is a constant discussion between the members of the team from all different disciplines, and we will probably adapt our program and we adapt our assessment process continuously according to the findings we have, according to the experience we make with the patients, according also to the experience the patients will tell us. This would be in a nutshell what our program, what our idea of referral pathways and service provision is so far. Probably we have to change all this as soon as we have more information about what could be therapeutic strategies for this. I think a promising strategy right now is the idea for immunotherapy, which is discussed in neurological papers right now, and the idea of kind of reducing the auto-antibody load. That might be something which explains these fatigue-like symptoms and many of the other symptoms like myalgias and others we see with the patients. I think this is probably a good introduction for our discussion, and I thought we had planned to have here 20 minutes of discussion. So I probably best hand back to Felicia and look forward to answer your questions together with Ian.
Thank you both very much indeed. Patrick and I are here. We're just overwhelmed, I have to say, by the volume of questions. And I think we'll start off with Patrick, if you would like to ask the first question, please, to our panelists.
Yes. Sorry, Flick, which one were you referring to, do you think, to start with?
Acupuncture, I think, to start with.
The acupuncture. Okay. The question came up about does acupuncture have any role to play in helping post-COVID complications? I have some views about this, but I'd like to hear from the panelists about that as well.
Having tried a few things, I would have to say it might. I can't say that it wouldn't. Try it, and if it works for you, I'm very pleased. Personally, I was a complete skeptic about mast cell activation syndrome and high histamine diets, and I'm not one for recommending to my patients changing their diet, because they can never manage that anyway, and it makes your life miserable, and it's not my job to make people miserable, it's to give them a longer life. So I took H2 blocker, and it wasn't a brilliant get up and walk moment, couldn't say it obviously made a difference, but when I stopped taking it for 2 days, wow, did the symptoms come back after 48 hours. And then I realized I'd promised myself this little sort of N of 1 clinical trial, and I remembered I'd stopped taking it 2 days before, took a tablet, was curled up on the settee in pain with all my muscles hurting and everything else going wrong, and within 2 hours I was up and about and went out and mowed the lawn. So I'm pretty convinced now that that is a really useful thing to try, for example, but it might not work for everyone, you know, and it goes for everything, you know.
Yeah. Thanks, Ian. Lovely. Andreas, do you have a view about acupuncture?
Well, when you look at the pathophysiology, or at least what we understand from it right now, it looks like that hyperactivity in the CNS plays a role. Now, we know that acupuncture has a function as counter-irritation to suppress hyperactivity. Usually this is on the spinal level and not on the brain level. So I'm not sure that the target is reached by acupuncture. Theoretically, yes, because it's a desensitizing method, yeah, but it might not work because the spinal level might be less important than the brain level.
Thank you very much. Okay, that's really helpful. I think, you know, we know from the extensive research that's been done looking at acupuncture with non-specific low back pain, for example, that the evidence remains really unclear as to what it can do and the outcomes. However, there are always a small group of people who will swear by it and say that it saved their life, and I think that's true for so many things. But on an evidence base, it's difficult to recommend it, certainly for most of the pain that we see in pain clinics. But again, I think I just echo on Ian's point really, which is that for some people it can be really helpful, and it's in that sense we should never abandon things purely on the basis that it doesn't help the majority. I just would make one more comment, which is that I think we're still exploring long COVID. If we start to think about it as a long-term condition, then we have to start thinking about self-management, and it's exactly the same as many other long-term painful conditions, where the importance of what people do for themselves begins to outweigh, I think, the reliance on expert help. So maybe we'll come back to the discussion a bit later on.
I like your comment about learning to sort of pace and self-manage, because there wasn't anybody I could particularly turn to. I realized I had to turn to myself and find out about this condition and kind of deal with it myself in discussion with a few select others. But yeah, that is important. But actually, I would tell people, yes, do this. Find out what works for you. In the sense of, I wish somebody had told me that at the beginning. that it was going to be chronic relapsing. Fine. Once I realized after a couple of cycles, you sort of, your mind gets better.
Yeah. Thanks, Ian. Yeah, no, I think that's important. I think, you know, one of the things, I'll just sort of maybe make this point that's very clear, that was coming out sort of through last year, was that the general sort of perception of COVID-19 was a pretty binary one. You know, it was either you know, you were severe and you had to go to hospital and you were at risk of dying, or you had it mild and you just stayed at home and got on with it.
Yeah.
What was not clear was that there was a third sort of a third way, to coin a phrase, where you know, that actually there were people who didn't necessarily end up in hospital, but who could end up with these long-term symptoms. And for many people, I think the sort of isolation that they felt and not knowing who to ask, exactly what you were saying, Ian, starts to create distress, and of course that creates a vicious circle. And there's enormous amount of crossover in this arena with things like conditions like fibromyalgia and other things, where people on their own have no idea what they're trying to deal with. And
that's interesting that you say this about this special situation at home. You know, usually in the first big moment, and you think about it, you feel like, well, if you can stay at home, everything is fine. It's only a mild or moderate infection. But in our interviews we do, we take a special interest in questions around, did the person at home feel isolated, helpless? Did he have support from his local doctor, from family, from friends, or no support at all? Because our hypothesis is that somebody in the hospital might have more severe disease, but he also might feel taken care of, while somebody staying at home might have milder symptoms, but he might feel completely lost, and maybe every night falling asleep with being afraid that this night he might wake up in dyspnea and needs to go with an ambulance to the hospital. So this is where we take a special interest in our interviews in this problem.
That's interesting. There was data presented at a Royal Society of Medicine meeting just last week that individuals from Black and minority ethnic backgrounds are significantly less likely to develop long COVID, but of course they are significantly more likely to go into the severe category, go to hospital and die. So I think this is telling us that your body, your immune system perhaps, takes an early decision to send you into the severe, nearly, you know, probably die category, or you get something else, which is a different route in terms of pathology, which I find really, you know, that's really strong evidence that long COVID is a separate thing. It isn't just a simple extension of COVID, no way, because I'd got over COVID and I got over it for a month, and then I developed long COVID, and many others described that gap.
Thank you very much, both of you. I've got a question, Ian, which is for you. There's quite a few questions on this same topic. It's about anticoagulation and thromboprophylaxis. So do you feel that your aspirin that you were taking preemptively to try and reduce your chances of developing, you know, bowel cancer played a role? And what do you think is the role of early anticoagulation in patients who have suspected COVID in the acute phase?
Yeah, that's an interesting one. It's tricky to advise on therapy as a doctor on social media, but as I'm semi-retired and I'm not paid, so whatever, my advice to all my friends has been, if you think you are developing COVID, take a good slug of aspirin, because it will anticoagulate your platelets for a good fortnight, and that might get you over the worst of it. When I saw those pictures of thrombosed kidneys, it really made me think. And when I did that antibody test on day 20, because a friend of mine is in the business and sent me a kit to try, I had to get 2 drops of blood out of my finger. And I thought, oh, well, that's easy, because it's normally one stab and then press and hold to stop it bleeding. I got 1 drop out, got it onto the test cassette. And when I went back for the second, the blood had set. It hadn't just clotted, it had set on the outside of my finger. So no doubt my interleukin-6 had fired my liver up to produce so much clotting factor. And I thought, quick, right, get the test going with only half the amount of blood. But after the event, you think, crikey, if that's how thick my blood is now, what on earth was it doing like a week or so ago? So I think there is definitely a place for giving somebody something simple like aspirin, because it has a very low toxicity and side effects profile as a sort of a chunk, or just taking it a bit, especially compared to what SARS-CoV-2 can do to you. And if that is what kept me the better side of the line, I can't prove it, but there is a trial in the UK actually of the use of aspirin in acute COVID, and I don't know what results have come out of it, if any. But it can't hurt, and also it'll have an effect on inflammation and pain as well. That's all I can say. It's an N=1. Let's put it this way. I really, really, really would not have liked to have been exposed to SARS-CoV-2 without aspirin cover.
Thank you.
You make your mind up whether you take it.
So, Andreas, have you got any experience, or do you think in your patient population that you're seeing coming to clinic, have you actually identified those patients who are taking thromboprophylaxis beforehand in any form whatsoever?
Well, in Germany, from the very beginning, there was a guideline on how to use thromboembolic prophylaxis. And it was only recommended for hospitalized patients. And then the standard is low molecular heparin or fondaparinux. And in patients who have additional risk factors, there are more sophisticated recommendations, but there was no recommendation for kind of self-treatment at home. And I have not seen a study or review on that this recommendation should be reconsidered, that there is something different from it. I know that some private practitioners visiting patients at home were putting patients on low molecular heparin and dexamethasone, but how many these patients are, we don't know. We have this in our survey, so we might tell you later when we have a greater number of patients how many patients took low molecular heparins or dexamethasone at home by themselves or by recommendation of the private practitioner.
I am aware of considerable research interest into mechanisms of hypercoagulability, and I don't have, for example, the strange platelet factor 4 thing that's associated with AZ vaccine. I don't have antiphospholipid syndrome, but I know a lot of people with long COVID who do have that. And I was contacted by a blood clotting clinician in the US after I declared my CVT on Twitter. And he said that his lab was already completely occupied with looking at auto antibodies to clotting factors that had been set off in people with long COVID. So there probably is no simple solution as to what is going on here. But it seems that this disease sets off problems at the acute disease and perhaps longer term.
Okay, thanks. Thanks, Ian. Sorry, Vic, I was interrupting. Yeah, I was just having a look through the questions. There are quite a lot asking about psychological approaches or psychologically based approaches such as ACT, acceptance and commitment therapy, CBT, the use of mindfulness, meditation, and so on, which again I'll come back to in a minute perhaps, and we'll have a discussion about that. There are also questions about the use of drugs such as pregabalin, gabapentin, I've noticed that, and duloxetine has been listed as well. So drugs that are used often in pain clinics, and a role for lignocaine. I think that's a reference to lignocaine infusion. So Andreas, would you like to maybe respond to any of those?
Well, the point is, if it comes to psychological issues, I think you would be probably the better one to ask, because all I know about this, I know from my psychologists. Yeah? And
Sure.
they opted very strongly for ACT because they said, well, we don't have any, how to say, specific foci, and it's kind of a subacute illness situation.
Mm-hmm.
Somebody's asking here in the chat, and it is really something different. We're not talking about prolonged recovery. We are talking about a new illness. And this is why we have this 3 months period between end of infection and beginning of calling it long COVID. And this is a nice, not a WHO, but a nice NICE recommendation. When it comes to the choice of pharmacotherapy, to my mind, there is no difference between long COVID patients and other patients. So it's a symptom-orientated and etiology-orientated treatment. Pregabalin, gabapentin makes sense if the patient has something like a polyneuropathy symptoms. Same thing would also make sense for duloxetine. Right now, most patients seem to have more myalgias and polyarthralgias, but there are also some patients with dysesthesias and paresthesias. So theoretically, one of these drugs might be helpful, though our concept is not to put the patients on 3 different drugs, but better see how they can cope better. But theoretically, it makes sense. Another thing is if the anxiety plays a role, because here pregabalin might be good. It's not a good analgesic, but it's very good anxiolytic. Of course, you have to think about dependence problems, and pregabalin, it's difficult to get patients off from it. Duloxetine might be a good choice for milder to moderate depressive symptoms, when at the same time the patient has paresthesias and dysesthesias. Yeah? But this is not a special recommendation for long COVID. This is a general recommendation. If you would ask a neurologist, a pain therapist, or anybody else would do the same thing.
Yeah, sure. Thank you. Thank you. I was just thinking actually that the people that I see, the commonest reason people want to come off, particularly pregabalin, gabapentin, is the brain fog that comes with those drugs. And of course, that's being cited as a significant part of long COVID as well. So I think although it may be helpful, just as you were explaining, and that's very clear. Thank you. I suspect that it may also have the effect of ramping up some of the difficulties that people are already experiencing and creating more problems.
I've remembered that one thing I did find was that the muscle pain is very interesting. It's kind of low level, but because you have so much muscle, it's a lot of pain. And I can remember at times just curled up on the sofa moaning quietly to myself because I didn't want my family to hear it. And I did find that simply taking ibuprofen was quite good, actually, at seeing it off. The other thing I found that was really good for the sort of sum total of all the pain was to see a doctor, the consultant finally, who took you seriously, wanted to do some major diagnostic tests to either find serious stuff or exclude it. And the sense of relief and sense of kind of caring did everything for your psyche. And comparing notes with my friends who've also been seen in that clinic, we all broke down at some stage and we all felt much better afterwards. And there was absolutely no need for us to go to our GPs and request antidepressants and anti-anxiolytics and stuff. So if you want to fill your GP's clinics with people demanding antidepressants and anti-anxiolytics, don't see them properly for long COVID would be my advice. But if you do see them properly and explain to them, you can expect to have this, that, and the other, and it will come and go, and it won't be nice, but in time it will get better. People will understand and react accordingly as humans do, I think.
Thank you for saying that, Ian, because I think that's very, very interesting, and is exactly the thing that, again, people with fibromyalgia, chronic widespread pain, often chronic
Okay.
fatigue.
Yeah.
They say exactly the same thing. When they say, you know, we have groups of people, and somebody says, "Oh, I have a good GP," and we say to them, "Well, what does that mean?" They say, "Well,
yes.
they listened.
Yes,
it wasn't that they rattled off hundreds of referrals or tests.
Yes.
They listened,
yes.
and took it seriously." And now we know that those things have an enormously calming effect on people's nervous systems, if you like. And one of the things, you know, that's a really important starting point is getting that kind of reassurance, being believed, if you like, is usually the thing that's said. And I just wanted to make this quick point that we talk about biopsychosocial. A lot of stuff that we do in that arena is bio and psycho. The bit we always miss out is the social. And this is becoming increasingly important over time. We're beginning to realize this, and how this manifests to the individual. I think, Ian, you've said this already in many ways. It's finding out it's not just me. You know, that's an enormously powerful factor. And so, you know, and as a good GP or any health professional, you can do a lot by A, listening, B, acknowledging that, yes, this is what we'd expect. And as I say, I think, you know, the story that we need around this is beginning to emerge. And that's just as you said, Ian, it's enormously powerful in terms of helping people.
Just one quick point. I mentioned, like, sort of some of the things that had caused me maximal pain, and one was at the age of 16 having an alcoholic dentist who later took his own life drill into a filling that he'd done incorrectly without an anesthetic when I had a root abscess, and he drilled right into the floor of the tooth, having drilled it all away, and said, "There's nothing wrong there." And I said, "No, there is." And he drilled into the bottom of the tooth, the pus came out, and there was pain relief. But while he was drilling, the dental nurse came up and behind and put her hands either side of my head, and the pain went. I mean, it was bending the needle on the dial when it was doing it. The moment she put her hands on my head, the pain went. And that taught me about the laying on of hands. So seeing people in over Zoom and stuff, yes, it has a role, but actually, if you see them as a human being, as a patient, as a doctor, and you put your hands on them, that does so much for right. It won't take everything away, but it'll take a lot away. I can tell you that for nothing. You know, we are human, and we respond like that.
Absolutely.
Thank you.
Thank you very much, Ian.
Thank you. I think touch is very important. That's one of the things I've not experienced, you know, whilst being in a hospital inpatient myself, and everybody's wearing latex. It's that skin to skin contact and the active listening. So we have 2 minutes left, and the team from EFIC would just like to share a couple of slides with you. But I would just like to say my heartfelt thanks, not only to my co-chair, Patrick, who brings with him all of his life experience and experience of being such an excellent clinician, but also thank you to Ian for sharing his story. It's a very personal story. Andreas, for all that you're doing for everybody in providing them with really joined up, you know, biopsychosocial care, and to the audience as well for your questions. And hopefully we've answered some of them, but what we will endeavour to do is actually get our two speakers to identify some of the key questions, and we'll be sending out some responses to those. So I'm sorry, thunderstorm persists. So just hand over to my colleagues in EFIC. Thank you.
Thank you so much, Felicia, and thank you, everyone. As this was a very, very informative webinar, we would just like to stress from the European Pain Federation EFIC that one of our main goals is to advance pain education, and especially in the times as now, it's just more and more important to increase your knowledge on this and advance your skills, which is why I just would like to briefly draw your attention to the EFIC Academy. which is a wonderful resource that has been specifically launched for the post-COVID-19 area. So to make online education relevant, and more accessible, no matter where you are in the world. Because medical professionals are just in a greater need now to find online educational opportunities. So this is a comprehensive multi-professional educational program. It has specific content targeted towards nurses, physicians, physiotherapists, and psychologists. As a member, you receive a lot of access to our projects as well as discounts for the Congress, our pain education summit taking place later this year, and our pain exams. You'll see some benefits here. There's reductions. There's obviously also, most importantly, the opportunity to learn from and study with peers and leading European educators. So if you want to find out more, you can have a look at the EFIC Academy education platform, which is only for EFIC Academy members, has over 120 sessions available right now, with more to be added very, very soon, and has tailored material to our 4 curricula, where you can pursue either self-directed learning or just follow your specific tracks that are relevant to your profession. This is the Academy board, guided by the highest level of European pain education expertise. And we have lots of members from all sorts of backgrounds, Academy board members, who are very, very excited to share their knowledge with everyone else. Just a quick note on pricing. You see it's very, very reasonably priced. This is the rate per month, whether you're a physician, a physiotherapist, a psychologist, a nurse, or even a student. It's a really, really good resource for you to have a look at. Join us today. You'll see the link here. It's academy.europeanpainfederation.eu. Thank you, everyone. Thank you to all the panelists. Please look out for this webinar. We will share it on our website and also our social media channels, and you will hear from us. And as Felicia mentioned, this is the first in a series of 3. So feel free to save the date and find out soon when the next webinar is going to be. Thank you so much, everyone. Have a good night.